Welcome to the Great Birth Rebellion podcast. I'm your host, Dr. Melanie Jackson. I'm a clinical and research midwife with my PhD, and each episode I cast a critical eye over current maternity care practice by grappling with research and historical knowledge to help you get the best out of your pregnancy, birth, and postpartum journey. Welcome to today's episode of the Great Birth Rebellion. I'm your host, Dr. Melanie Jackson, and today I'm looking at the question, rather than asking, is home birth safe? I'd like to ask the question, is hospital birth dangerous? If every listener in this podcast represented a member of the general public and we were all childbearing women, the vast majority, approximately 97% of you, would go to hospital to give birth. And I know probably the listenership of this podcast would be slightly different. Probably less than 97% would go to hospital to give birth. But if we're looking at the general public, here in Australia, 97% go to hospital to give birth. And most of you would tell me that going to a hospital is important because birth can be complicated and things can go wrong. And without an expert in the room, you could be putting yourself in danger because birth is dangerous. That's what you would tell me. You could bleed too much. Your baby could get stuck. You could have a huge tear that needs repairing. Your baby could get stressed in labour and you might need a cesarean section. There's so many things that could go wrong. And in order to uphold the current maternity care infrastructure, so the way that our maternity care system is set up, there is a social and cultural reliance on members of the public agreeing that birth is dangerous. And it's important to the maternity care system that we have a fear of pregnancy and birth so that we continue to believe that the best way to keep everyone safe is to give birth in a place where all the experts are gathered and they have their equipment and they have their medicine and they have everything that they need to keep you safe, all there in that one building. So this is hospital birth. And at a hospital, they can deal with any birth emergency, and so you're considered to be safe there. So let's first have a look at this concept of birth as dangerous. And there are two philosophies about birth that exist on a spectrum. And if you've been following me on Instagram for a little while, you'll notice that recently I put up a tile about the medicalization spectrum. It's something that I've shared before, but it's really helpful to get a visual understanding of what I've been talking about in this episode and what I'll continue to talk about. And if you're on the mailing list, I'll also be sure to put those tiles in the resource folder and you get access to those every week. So if you want access to the visuals that I'm using to create today's episode, feel free to join the mailing list for the podcast at melaniethemidwife.com and you'll get all the resources. So what's this definition? The definition of medicalization. So medicalization is the process by which non-medical events become defined and treated as medical problems. So these are often physiological events or human differences, and they become redefined as pathological, so they get redefined as a state of illness. And therefore, when it becomes under the illness spectrum, then that gives medicine and medical doctors permission to take ownership of and treat this illness. And this is what's happened to childbirth, is that it's been brought under the medicalization umbrella, and we'll keep talking about that as we go. But for now, just remember that birth wasn't always medical, but through a process of medicalization where it's been redefined as pathological, we now use medicalized terms to talk about birth, but it wasn't always that way. So if we have a look at this medicalization spectrum, at one end of the spectrum, we have a philosophy that believes that birth is just a physiological process. So this is the physiological end of the spectrum, and it's the least medical end. And so this physiological philosophy believes that our bodies are designed to give birth much in the same way as pooing and weeing and vomiting and having an orgasm and ejaculating and digesting. Birth is just another normal process that our body's capable of executing, and it's an inbuilt physiological process that we don't normally need help with. And when it's time to give birth, all the hormonal processes that occur in our brain and act in our body get activated and the process just unfolds. So for people with this philosophical understanding of birth, where they believe it's a physiological event, there's an understanding that sometimes there can be a complication and a dysfunction in the process. Just like all other physiological processes, they don't always work as they should, and sometimes we need help. But for the most part, it works just fine. So this philosophy is usually held by many midwives and late birth workers, and women who have a physiological belief about birth are most likely to choose the care of a lay birth worker or a midwife to care for them if they have this physiological philosophy, this physiological mindset about birth, because that matches what they personally believe. Now, this exists along a spectrum. So, the other end of the spectrum, the very extreme end, is the biomedical philosophy, or we can just call it the medical philosophy, where there is a belief that women's bodies are inherently flawed, and most of the time, they don't have the capacity to give birth without some medical input. So under this philosophy, under this biomedical philosophy, birth is considered to be mostly a dangerous event that needs supervising and interventions in order to keep it on a safe path. And so there's a belief that women don't have the capacity to give birth without some medical input. And so we need medical help to have our babies. And under this philosophy, our bodies are flawed and the birth process is fraught with danger and it can't be trusted. So it needs very close supervision, and medically minded people are invested in creating lots of gadgets whose function it is to measure and monitor the activity of labour in order to detect and save us from the dysfunctional process of birth. And so when we have this belief, we see that we need professionals to get expert training to save us and qualify themselves to monitor and manage us so that we're kept safe from our failing bodies. So many women also believe that their body is not capable and they can't trust it to give birth safely. And so they will hire the most highly trained expert, the most highly trained medical expert, to care for them, to give them more confidence. And if and when their body fails, there's an expert there to save them and their baby. So this is, if you hold a biomedical philosophy, this is what your brain is thinking. And the most likely health professionals who hold this biomedical or medical philosophy are sometimes midwives, actually, because although we are trained to have a physiological mindset, we often get groomed and adopted into the biomedical mindset by our workplace. And then also obstetricians are trained to manage obstetric emergencies, and often, but not always, they start to believe that birth is more likely to go wrong than not, and that they are an integral part of the birth process. Obviously, these are two extreme ends of the spectrum. The physiological philosophy sits at one end and the biomedical philosophy sits at the other end. There is a long spectrum in between and a lot of mixing and nuance. So I'm just using these two philosophies to make a point. It makes the point that there are two ends that sit along a spectrum, and women and care providers can sit anywhere along that spectrum. Now, again, if you've been on my Instagram at Melanie the Midwife, and I'll also post this tile at the Great Birth Rebellion Instagram page, I've got an image of the medicalisation spectrum, and superimposed with it are all the different birthplace options that a woman could choose, and I've plotted them from least medical to most medical. So if we pair each birth philosophy along with the corresponding birthplaces, we see that at the physiological end, at the least medical end of birth options, we have the option of free birth, which we've spoken about on this podcast before, of home birth with a private midwife. There's also the option of home birth with a public midwife. And then we start to move into some institutions, and we move along the spectrum, coming a bit more centrally along the spectrum to a detached birth centre or a private birth centre, an integrated birth centre where the birth centre is actually inside the hospital unit. Then we have the public hospital midwifery continuity of care programs with the midwives. And now we're starting to move closer to the biomedical philosophy end of the spectrum, where birth practices and birth philosophies become more medical. So we move into the public hospital with just standard fragmented care, then a public hospital with a public doctor if you've been put into the higher risk clinic, then the public hospital with a private doctor, and then on the most medicalised end of the spectrum, particularly if we look at birth outcomes, so women who give birth in a private hospital are most likely to receive a high number of interventions. If you give birth with a private obstetrician in a private hospital, you are most likely to be positioned within a biomedical philosophy and therefore also receive statistically speaking, a higher number of interventions. Again, there are definitely outliers. I know personally of private obstetricians who are incredibly physiologically minded, but they're few and far between. So don't have an expectation of that. You need to find those people. Again, if you want a full visual of this, check out the Instagram pages or get on the mailing list for the Great Birth Rebellion podcast at melaniethemidwife.com, and you'll have access to this visual demonstration of what I'm talking about. Now, the situation that I described earlier, when 97% of Australian women will go to hospital to give birth, is what most people would see as the normal way to give birth at this point in history. But it wasn't always like this. The practice of obstetrics is a relatively new invention all over the world, and obstetricians or doctors have only been attending births here in Australia for around 120 years. And the historical takeover of birth would be different depending on locations. But certainly what happened here in Australia in regards to the takeover is not dissimilar from what we saw in European countries, in the UK and in the US, particularly because Australia is a colony of England and the UK. So prior to approximately 120 years ago, prior to that, the care of women during pregnancy, in childbirth and postpartum was the domain of wise medicine women and of midwives and community elders who handed down midwifery skills through the process of lifelong apprenticeship. And the midwives were responsible for the health of women and their babies, and as a result, they were cared for by their community and considered an integral part of the social and community fabric. And so historical accounts of midwives framed them as being revered and honoured and respected and sacred members of society. They weren't government-owned or employed care providers. They were community members chosen by the community to be in this role. And birth was the domain of women, and it happened in community. There weren't hospitals. Birth happened in women's homes or in sacred spaces that were reserved for birth. And here in Australia, the move from giving birth at home to giving birth in hospital was motivated by two events. The first event that motivated the move from home to hospital was firstly colonisation of Australia by European settlers, which commenced in 1788. And then again at the end of World War I, around the 1920s, when Australia had entered a profound phase of poverty. And the historical records of this time suggest that there was a marked increase in the number of doctor-managed births between the 1900s and 1940. So that's not that long ago. 80 to 120 years ago were the first records that started to note a marked increase in the number of doctors that were managing births. They were still in the home. It wasn't like doctors had set up hospitals or anything like that. They were going to women's home to assist them in birth. And it was noted at the time, as these records were being gathered, that the more affluent middle-class women, the wealthier women who were attended by doctors, ran a greater risk of infection than did the poorer women who were attended by midwives. So this is historical knowledge about the change of birth around the 1900s to the 1940s. And at this time in Australia, home births was still the norm, even though doctors had started to become involved in birth. It wasn't until after World War I, around the 1920s, where there was a trend towards hospital birth. And as I said before, the reason for this wasn't that they needed a solution to birth complications, but rather it was the introduction of what was called laying-in hospitals, which were a public service to poor women. So these laying-in hospitals were created for women who, due to unemployment and the depression post-war, were living in increasingly overcrowded conditions with not enough food, poor hygiene, and they lacked the basic requirements that were needed to keep a baby and themselves healthy through the birth and the early weeks afterwards. And so these laying-in hospitals were created more so as a solution to poverty than a solution to birth complications. And the birth process in these laying-in hospitals ensured that there was a cleaner birth space and that the woman had food and shelter, and they also provided some resources and clothes for the baby. And the poor relied on the lying-in hospitals. But these were seen as inferior to being in your own home, and the wealthy continued to employ private midwives and their family physician, a role which had been growing over this time. And they remained at home to give birth well into the 1950s, at least here in Australia. And as poverty got worse, the middle class increasingly disappeared. And as the Depression took hold, with the number of poor increasing rapidly, the number of women who could afford to employ a community midwife and a private midwife to be with them in their home diminished. And so more women required the public service of these lying-in hospitals, which were now staffed by the newly medically trained nurse midwives, not the wise, experienced traditional midwives who'd been tending to the women at home. So this led to the rise of the more prestigious hospital midwives or hospital nurse midwives, who were starting to be seen as superior because they had formal Western training and certification like a doctor would. And in a newly colonized society, this was valued over the traditional knowledge and medicine and skills, remembering that they were attempting to set up a European colony. And so they valued Western and medical ways of doing things. And so these new hospital midwives were considered superior, medically trained midwives. Now, the affluent continued to have their babies at home through to around the 1940s. But from the 1940s onwards, doctors had managed to use deceptive and misogynistic methods to discredit the work of community midwives, and the hospital midwives were relegated to a role of servitude to the doctor's wishes. And so doctors managed to monopolize birth, and they financially benefited from caring for pregnant and birthing women because there was a growing GP trade developing here in Australia. And GPs were looking for ways to recruit families into their care. So as the medicalisation of childbirth took hold in Australia from the 1940s onwards, doctors were recruiting pregnant women with the thought that they could build themselves a client base, because back then you would be a family GP, you would care for the whole family through their whole life cycle, and it kind of guaranteed a client base and clientele for a growing practice. And so the move to hospital was firstly motivated by caring for the poor in the laying-in hospitals, then accentuated by the practice of medicalisation and colonisation of birth, and it was further motivated because doctors financially benefited from taking ownership of the birth process and bringing it under the medical purview. In 1972, there was a published claim that all babies in Australia were born in hospitals. And then in 1982, they started to record a resurgence in home birth. So 10 years later, a report claimed that 5,000 babies were born at home. and obviously most of these were attended by midwives. And so that's how it ended up that 97% of women give birth in hospital here in Australia. That is a brief historical rundown of the takeover of birth, where it was moved from community and from community-trained midwives and into hospital, then being cared by medical staff and university-trained staff over a period of about 100 years. But was it a good move? Has it made us safer and healthier to have moved birth into a hospital setting with medical supervision rather than being cared for by midwives in a home setting? Well, let's have a look. As I said, 1900s to 1940s seemed to be the time where this big transition was taking place. And in 1933, there was a paper released in The Lancet in the peak of the transition from home to hospital. This was reported in the US and across Europe, and obviously we just heard that this was happening in Australia too in this time period. And so people were having a look at the outcomes. What happens when you move birth from home to hospital? And this is a quote from the 1933 paper, which is called The Safety of Childbirth. Again, there's a copy of this in the resource folder. I'll read the quotes because they speak for themselves. This paper says, "Among the changes which have been taking place in obstetric practice during this century, one of the most important is the increasing use of hospitals for birth. In a recent paper, De Lee and Steidenhoff discuss whether these recent changes in the practice of obstetrics have resulted in better welfare of mother and child, less loss of life, and greater protection of health. They come to the depressing conclusion that the increasing preference of the hospital as a place of birth seems not only not to have bettered the results, but seems actually to have made them worse. They also cite the Aberdeen report, which was important at the time, to show that, and this is a quote, there is a serious risk in the usual maternity ward which is absent in the usual confinement at home. Ease of intervention and a false sense of security in hospital have contributed to the increase in the number of artificial deliveries, which bring with them an increased mortality risk. Premature and unnecessary intervention have also been alleged as the reason why maternal mortality is higher in the practice of doctors than in the practice of midwives." This was written in 1933 amongst the transition from home to hospital. So back then, they identified that a medical way of caring for birth was actually creating a unique and increased risk to women. They didn't make much mention here of the babies, but at the very least, it wasn't working out well for women. So this does show that the calling out of inherent risks of hospital birth is not new. So while this transition was occurring, there was published research which told doctors, and there were numerous reports to indicate that hospitals were worsening outcomes for women compared to being at home with a midwife. So let's have a look now. What has changed now in the modern age of obstetrics? And we can compare what outcomes hospital managed birth is offering women now with what women might expect if they choose to give birth at home today. And the language that most people understand at this point in history is they want to know the physical outcomes of mums and babies. How many died? How many were seriously injured by their birth? How many cesareans? How much blood was lost? There are so many more outcome measures that could be used to explain the safety of different birthplaces. Over the world at the moment, the topic of obstetric violence and birth trauma is being highlighted in the news and in government and in policy change. And we're identifying that, yes, hospital birth and some home births is impacting upon their emotional safety. There's no doubt about that. But to talk about all the outcome measures would take this entire podcast all the time, which is obviously what we're doing. But today, I'm going to draw from a research paper called Maternal and Perinatal Outcomes by Planned Place of Birth in Australia, a linked population data study. And this is open access, so you can get full text access online, or if you want an easy click version, join the mailing list for the Great Birth Rebellion podcast. And so this particular study is what I'm going to use, and it's considered the most statistically authoritative paper here in Australia. And it mimicked a lot of what was already known about home birth outcomes versus hospital outcomes from smaller studies. But this was done on a larger scale. And so, the more numbers in a study like this, the more significant the results. So while yes, there are a number of subjective outcomes that we know are improved for women at home, but this particular study is looking at objective physical outcomes. If that's what you're interested in, this is the episode for you. So, maternal and perinatal outcomes by planned pace of birth in Australia, a linked population data study. We colloquially call this study the Birthplace in Australia study. And there was a similar one in England, but we're going to look at the Australian statistics at this one, but the Birthplace study in England is another option to look at. So this paper looked at women with uncomplicated pregnancies who gave birth between 2000 and 2012 to a single head-down baby at full term, so between 37 and 41 weeks. So what this study is saying is that these babies and women should have done well. They were the lowest of the lowest risk cohort that they could gather. So there could be no argument here that the outcomes were the fault or caused by the women and their faulty bodies, which is sometimes what's proposed, is that yes, there's an increase in intervention rates, but that's because women are getting older and fatter and sicker. And so women are starting to be blamed and have been blamed for the increased use of intervention in their births. But this study, they were the lowest of the lowest risk women they could study. And they looked at approximately 1,250,000 births. That's a rounded number. And of those births, 93.6% gave birth in hospital, 5.7% in birth centres, and 0.7% gave birth at home. And there was over 8,200 births at home. Now, spoiler alert, the results show that there were no statistically significant differences in the proportion of stillbirths or neonatal deaths, so that's deaths from birth to 28 days, between the three planned places of birth. So if you gave birth at home or a birth centre or hospital, statistically, your baby would have had very similar outcomes. Those are obviously physical outcomes, not emotional, social, or cultural outcomes. So the outcomes for baby were comparable, no statistically significant differences. All the babies did as well as each other, regardless of where they're born. So it was relatively good news for babies. Australia is a really safe place to be born physically, wherever their mother chooses to give birth. But how did the mothers do? So let's look at the likelihood of a normal birth without needing a caesarean section, forceps, or a vacuum. So these are babies who came out of their mother's vagina under maternal effort, and unfortunately here, this terminology of normal birth still included women who had an episiotomy. It just didn't include the women who had a caesarean, vacuum, or forceps. So again, these are the lowest risk women who were most unlikely to have a complication through their birth. If women chose to give birth at home, they had a 95.2% chance of a normal vaginal birth, without a caesarean, without forceps, without a vacuum. That number reduced if you go to a birth centre, 89.2%, and then it reduced again for the same type of woman giving birth in hospital, 78.6% gave birth without a caesarean, forceps, or vacuum at hospital, compared to 95.2% at home. Remembering that all of the babies had a statistically similar outcomes, but the home birth group managed to do it with 16% more women having uncomplicated vaginal births. So here we can see that the further away you give birth from a hospital, the better the outcomes will be for women, and the outcomes are still similar for babies. So already, the situation for women at home is significantly better The next thing that women and sometimes partners worry about is postpartum hemorrhage, a big postpartum hemorrhage. So this research project looked at postpartum hemorrhage where women lost over 1,000 mils of blood and also required a blood transfusion as a result. So, interestingly, the numbers are not significantly different. So if you're at home, 5.4 out of 1,000 women who gave birth at home lost over 1,000 mils of blood and required a blood transfusion. So 5.4 women in 1,000. So if 1,000 women were giving birth, 5.4 of them would require a transfusion because of the amount of blood they lost. This went down slightly at a birth centre, 3.4 women per 1,000. Interestingly, in hospital, it was 5.3 per 1,000. So the home and hospital ones were almost identical. And although this appears as though they are similar, they're actually significantly different. And I'll tell you why. Because in hospital, when you give birth, unless you tell them not to, unless your plan is not to do this, they will automatically give you an injection of artificial oxytocin into your leg after your baby is born. They will give you this injection, and the intention is to speed up the birth of the placenta. And so they give you the injection, they wait for signs of separation for a few minutes, then they will extract your placenta using a technique called controlled cord traction. So in layman's terms, they pull your placenta out by the cord. So that's how hospitals will manage a placental birth. The reason they do that is because they believe that by doing what's called this active management with the injection and pulling your placenta out, that they're going to reduce the chances of you having a significant postpartum hemorrhage and requiring treatment for a postpartum hemorrhage. Interestingly, the stats are the same if you give birth at home. However, we don't use active management routinely at home. At home, we wait for your placenta to be born. And we believe that just as the baby can be born without too much medical intervention or no medical intervention at all, so too can a placenta. So we don't routinely use active management. We don't routinely use the injection of oxytocin. We use physiological management of placental birth, which essentially means providing a supportive environment that's quiet, where the baby and mum are kept together, where we encourage the woman to breastfeed, remain in an upright position, we keep her warm, and we keep the space quiet and private so that the physiological flow that needs to happen on the hormonal cascade that happens for placental birth doesn't get interrupted. And using that technique, the woman, under her own effort, can give birth to her placenta. What these stats show is that managing placental birth physiologically versus routine intervention and the active management of placental birth hasn't, in this circumstance, made a difference in the number of women who are having postpartum hemorrhages greater than 1,000 mils that require a blood transfusion. So although the rates of bleeding are similar, the technique is very, very different, and it appears as though even though almost every woman is getting medically managed placental birth in hospital, it doesn't appear to be making a difference to the outcomes for severe postpartum hemorrhage, according to this study. The least likely chance of having a postpartum hemorrhage requiring a blood transfusion happens to be at a birth centre this time. We can speculate as to the reasons for that, but this study doesn't particularly go into it. It was more so looking at statistical analysis of these data. So again, although the stats are similar, women are exposed to far less intervention at home with no change in the outcome for themselves or their babies in this regard for postpartum hemorrhage. Let's have a look at the stats for in-labour caesarean sections. So if you plan to give birth at home, you've got a 2.4% chance of going into labour but then ultimately needing a caesarean section for your birth. If you go to a birth centre, there's a 4% chance that you will require transfer for a caesarean section. If you go to hospital in this study, according to this study, as a low-risk woman, then you've got a 7.8% chance of a cesarean section during labour. So again, approximately 5% more chance of having a cesarean section if you go to hospital versus if you give birth at home. And the main point here is also that even though these women have received more intervention, more cesarean sections, more medication, it's not like these interventions have improved the outcomes for babies. It's despite all these interventions, they haven't changed outcome for babies, but women have been exposed to far more interventions in hospital to get the same outcomes compared to women who have given birth at home. So again, here with the cesarean section rate, we can see that women are far better off when giving birth at home compared to going to hospital in terms of their physical outcomes. Let's have a look at the combined vacuum and forceps stats. So if you stay at home, or if you plan to give birth at home as a low-risk woman, there's a 2% chance of either requiring a vacuum or forceps. If you go to a birth centre, there's a 6% chance of either requiring vacuum or forceps. If you go to hospital, 11.8% of low-risk women will give birth by the use of vacuum or forceps, compared to 2% for women who give birth at home. Significantly better outcomes for women who give birth at home compared to hospital, especially in this regard to vacuum, forceps, but also we saw for cesarean section. Augmentation of labour is next. If you'd like to see a visual representation of all the things I'm talking about, again, mailing list, charts, those are your friends, they'll all be there. Let's have a look at augmentation of labour with oxytocin medication. So this is where you've already gone into labour, and then for one reason or another, your care provider recommends that we speed the labour up. They use a drip of oxytocin for this, and we call it augmentation of labour. Now, if you give birth at home, 3.4% of women are transferred for the purpose of augmentation and receive it. If you go to a birth centre, it's 8.1%. If you are in hospital as a low-risk woman and you've gone into labour, 16.5% chance that you will be given oxytocin to speed up your labour. That's 3.4% if you're at home and 8.1% if you're at a birth centre. Significantly more likely to be augmented if you go to hospital to have your baby. It's not going to make much of a difference to your baby statistically, but as we can see here again, the hospital gives women far more interventions for no significant changes in the outcomes for babies. But as we can see here, women are exposed to far more intervention and the risks of those in hospitals than they are at home. All right, let's have a look at this next one. How many women experience no perineal tears or trauma at all? So that perineal area, the space between your vaginal opening and your anus on the outside. If you're having a baby, that's the area that's most likely to come away and tear for the birth of your baby. And we've got episodes on this in the podcast, remembering that the perineal area was designed to receive a baby into it and to act however it needs to act when the baby's coming through. So there is a tendency for it to tear, not for all women, but let's remember that it also has the capacity to repair. Our bodies are very, very clever and very well made for this purpose. So if you give birth at home, then the chances of having no tears to your perineum at all are 47.2%. The chance of having an intact perineum reduces if you go to a birth centre, 30%. If you go to hospital, you've got 26.3% chance of having no tears. Again, significantly better perineal outcomes for women who give birth at home. And this final one, if you're not already flabbergasted and infuriated, episiotomies. So an episiotomy, for new players, if you're at full stretch, your baby is so tightly placed on your perineum that you're feeling that your vaginal opening is at full stretch. And for one reason or another, your baby is not coming as fast as your clinician expects it to be coming, or if they have some concerns for your baby's well-being, they'll offer you the opportunity, or unfortunately sometimes will cut an episiotomy without your consent. And an episiotomy is a surgical cut designed to increase the size of the vaginal opening and theoretically speed up the birth of the baby. Now, the usual only reason that we would do this, according to the research, is if we have grave concerns for the well-being of the baby, and the only thing holding the baby back from being born is the perineum. And so this is supposed to be an emergency strategy to help an unwell baby be born sooner so it can get medical attention. Now, if you give birth at home, this would occur 2.6% of the time. If you go to a birth centre, 8.3%. If you go to hospital as a low-risk woman who's expected to have a good outcome for her birth because there's no pre-existing complications, you will likely get an episiotomy 17.3% of the time. So either hospital birth strategies are putting babies at so much risk that 17.3% of babies are in poor condition at the time of crowning, and so they're requiring more episiotomies in order to rescue more unwell babies, or there's an incredible and gross overuse of episiotomies as an intervention, and 17.3% of women are having their perineal bodies cut into through the use of episiotomy. Either way, it hasn't improved outcomes for babies who are born in hospital. And so a huge number of women are experiencing episiotomies at no benefit to their babies and at the detriment of their own bodies. If this isn't proof that hospital birth is more dangerous for women than home birth, then I don't know what is, because they're not improving outcomes statistically overall from this study for babies, but it's clear that they're worsening them for women. So, in this study, maternal and perinatal outcomes by planned place of birth in Australia, a linked population data study, the outcomes here have shown what previous studies into home birth have shown in the past, that home birth, accompanied by midwives in countries with access to adequate health care, have the same, and some say better, outcomes for babies, but far better, as we have seen, far better outcomes for women when they give birth at home. Compared with planned hospital births, the odds of normal labour and birth were over twice as high in a planned birth centre and nearly 6 times as high in planned home births. There were no statistically significant differences in the proportion of intrapartum stillbirths or early or late neonatal deaths between the 3 planned birthplaces. The research evidence is undoubtedly clear that home birth is significantly, without a shadow of a doubt, better for women in physical outcomes and equal to each other if we look at outcomes for the baby. This is what the evidence has systematically shown us. There are some differences and some nuances to look at for women having their first babies, but what I believe from this research and from previous smaller studies that have come before it is that it's time to stop asking, are midwives and home births safe? And start asking, is hospital birth and routine medical care for women in labour and birth dangerous? To get free access to all the research that's used to create each podcast episode, you can join the mailing list at melaniethemidwife.com, or you can join our members hub and financially support the work of this podcast. In the hub, you can ask me questions, and premium members get access to a monthly Q&A episode where I answer listener questions. You'll also get episode transcripts and additional resources for each podcast episode. All the details are in the show notes.